Good afternoon, everyone. Thank you for joining us today on this webinar from wherever you are. It is my great privilege and honor to conduct proceedings today as we traverse the contours of a discipline often at the margins of medical discourse and which has become front and center in the age of pandemics in the most starkly relevant way. I'm Dr. Aslam Dasu, a convener of the Progressive Health Forum, which is a proud associate of the Palliative Care Action Group, your hosts at this webinar, in collaboration with the South African Medical Research Council. It's been a wonderful experience to have worked with a remarkable group of palliative care professionals and practitioners, academics and advocates in the Action Group over the last year. It's been a relearning for me and a reminder of the great importance that our healthcare training ascribes to palliative care, but which tends to suffer the inattention that the modern practice of medicine regrettably encourages. Palliative care is a fairly undramatic phrase to describe a healthcare discipline relevant to the most significant period of a life other than birth. It's a discipline informed not by science, expertise, and ethics alone, but also by the nexus with the fulsome expression of the empathy of the healthcare professional and the metaphysical philosophies and associated ritualized customs of all people that attend the process of dying. It's in this intersection that palliative care is fully evoked and becomes a fitting enterprise in the firmament of all healthcare. The science of palliative care is evolving like most of the practice of medicine. The development of instruments that can attenuate the suffering occasioned by life-shortening and terminal illness is perhaps one of the most innovative areas of medical research today, at a time when the focus on healthcare has never been as acute in the modern era. But the innovation is not confined to the cold, hard, and factual rigors of research only. It is also the evolution of how helpless human beings are valued when in the care of the modern health system, in which the priorities in the hierarchy of care swiftly change. Public health, the overarching framework that envelops all healthcare, even the private sort, is also undergirded by the philosophy and ethical remit of the notion that practitioners, however they are brought into the patient contract, have a natural inclination to the empathy that empowers that contract. Leaving aside for the moment the economics of this empathy, it should be clear that it is this quintessence, this consciousness, this life that is irreplaceable, irreproducible, and irredeemable. That is why the right to access healthcare is an irreducible human right. It's a realization that comes usually with time in practice, if at all, and often too late. It must be a central part of the training of all health workers. That it is not is quite evident in the negligence that often befouls the care of the sick, but which is inexcusable when it condemns the terminally afflicted to the ultimate indignity of dying in pain and discomfort. Memento Mori is the Latin phrase meaning, remember, you too must die, and is the modern refrain of the great tradition of the Stoics, the philosophers who number among the likes of Epictetus, Seneca, Lao Tzu, and others from the Eastern, Western, and Southern canons of philosophy. Memento Mori, remember, you too shall die, is an unspoken and mostly unconscious credo of the practitioners of the art and science of healing, not least because it frames palliative care with the knowledge of inevitability and the exigencies of the end of life, but also because it should be more consciously appreciated in order to give greater meaning and context to the practice of healthcare. The Stoics elaborated a detailed taxonomy of virtue, dividing virtue into four main types: wisdom, justice, courage, and moderation. While these virtues are splendid principles by which to live, I cannot imagine a more excellent set of animating principles for those who practice healthcare, nor greater inducement for them to bring it to bear in the exigencies of palliative care. For it is in the twilight of life that wisdom, justice, courage, and moderation bring the most succor and satisfaction. So what you will hear today from the distinguished array of speakers is the why, how, and wherefore for palliative care in the modern practice of medicine. But perhaps also understand why the pandemic offers the opportunity to raise our sights and become more engaged with and provide better care to those in need. At this point, I'd like to ask all the speakers to make themselves visible by putting on their cameras so that they can be viewed by the audience. Hello, everyone. Thank you all for being here. We will begin immediately now. Without further ado, let me introduce our first speaker, who fortunately is able to grace us with her presence due to the unavailability, unfortunately, of the Deputy Minister of Health, who is unfortunately otherwise engaged in important work. But Juanita Arance has graciously offered to step in, and we couldn't have hoped for a better substitute in this very important webinar. Ms. Arance has worked with the Western Cape Health Department since 1989, and she currently serves as the Chief Director, Emergency and Clinical Services Support for the province. She holds a Master's in Public Health from the University of the Western Cape, and she has deep experience in health systems management and monitoring, policy writing, and review and public financial management. Sorry, that should be policy writing and review and public financial management. In 2016, she took it upon herself to champion the implementation of palliative care in the province, and she's currently writing her doctorate thesis on this topic. Wonderful to have you, Juanita. The stage is yours. The rest of you can put your cameras off. It's all for Juanita right now.
Thank you so much, Dr. Dasu. Good afternoon, everybody. I shall share my screen and go straight to my presentation. And then just to thank you all for this opportunity to share with you what's been happening in the Western Cape. I will be speaking in particular around the model for implementation of the national policy framework and strategy on palliative care in the Western Cape. And you are all obviously very familiar with the national policy framework and strategy, and this is just to show you how we've aligned to that. So where it all started in the Western Cape. Now, historically, palliative care was rendered by hospices, intermediate care facilities, and step-down facilities for many, many years. And there was really just funding from the Western Cape Department of Health to these entities, either from our equitable share budgets or through global funding. But that was basically the role that the public sector services played. And the big gap was really in public sector with regards to offering palliative care, so to say. So in 2016, a first meeting was called by our Chief Director for the Metro Health Services with various stakeholders across the province. And to start talking about how do we start give effect to this and how do we start closing on that gap and ensuring that we offer universal health care. 2016 to 2017, we then went into a process of conducting a baseline survey to determine who was offering palliative care, where and how and what. And what we soon realized is that not everywhere, as we even thought, palliative care would be in place in its form, in its true form by definition, was really taking place. In 2017, we then established a palliative care task team, giving rise to about 11 sub-task teams dealing with things like research and training and finances and all of those things. And by 2018, in October, we were ready to actually launch our model for implementation of this national framework and strategy. And the big word on the table is integration. And we talk integration, it's not just about clinical integration, it's about systems integration and how one looks at the entire system, looking at stakeholders and partners and academia and all the actors in this framework and how everything comes together in the form of policy training, specialist financing, etc. And to make sure that it's something that we can collectively own. So I thought I'll give you guys an overview of just sort of the Western Cape palliative care model. And just to show you that on a community level, there's palliative care home visits and home-based care, as we historically spoke of it. We've got intermediate care facilities and inpatient hospices, that's all in place. Then we were looking at how we unpack things in the primary healthcare facilities and provide support to the community level, medication collections and delivery and support groups, etc. We also unpacked how we would approach it at a district hospital and regional hospital level. What shape and size would inpatient palliative care consultancy services look like? How would we designate palliative care beds where there is no access to intermediate care facilities, for example? And how would we also ensure support at all of those levels? And then we further unpacked what needs to be happening at a tertiary hospital level. So palliative care sort of teams led by the specialists in palliation, inpatient and outpatient consultancy services, what needs to happen with regard to training and teaching and outreach and support. And that's really how we had to grapple and get our heads around it. And the things that we had in place, so I'm just showing you a picture of some of home-based care. And I mean, this is kind of what we've had in place for many years from around about the year 2000. Home-based care services, and this is sort of the shape and size of what was already in place. We also have the various hospices like at Lentige Hospital, at St. Joseph's Home, and I can probably mention a good few across the entire province that are currently in place where we offer intermediate care services, and intermediate care being sort of a package of services of which palliative care is integral and crucial. And of course, our hospices with the Hospice Association and their support and working together with them, that was also in place. But I suppose the bottom line is there were still very many gaps. So we realized there was a big job that really lied ahead for us, for both adults and for pediatrics. And we had to look at how do we then take all of this that's in this model and how we try and make sense of it at the primary healthcare level, at our acute hospital level, at the tertiary and central hospital. And it's easier said than done than putting a document out there, but it's a process that needs to start. So through our task team, we had various engagements, we had various road shows that were being conducted and training had started. And these were all the things that we knew, this was the big job. This is what we had to get sorted. So since 2018, some progress that we have made, we've put a mini contract in place, first of all, just to at least kickstart our training. 133 health professionals were trained in the 40-hour course. Palliative care slowly but surely being implemented at varying degrees across the public sector facilities. And then we got as far as getting a formal course contract in place after that. And with a formal course contract, what we did there was we expanded the training even further. So a massive institution like Tygerberg or Groote Schuur, for example, would be able to, through this formalized contract, be able to access training for a group in their particular facility. And we could also lump people together from various areas at close proximity and make sure that everybody had access to this formalized contract. We also got permission for the skills budget in the department to be utilized for this particular training. And this was ongoing through from 2018, 19, and then 2020 also palliative care training continued. Our primary healthcare palliative care teams were being set up all across the metro and some rural areas as well. And then COVID-19 hits with still many gaps, you know, many visible gaps in palliative care service provision. And so we had to get our heads around, okay, you know what came with COVID-19? Obviously, that was just, if anything, it showed up the big gap we still had in palliative care. Fortunately, we were not at point zero. We were at least at some form of starting block, and we needed to gear ourselves and get a provincial palliative care plan for COVID-19 response in place. What I'm showing you now is sort of a patient flow for palliative care in the COVID-19 pandemic. And what we realized was we pulled, because we had the existing task team as well, we pulled the whole team together and we said, okay, look, let's get this going. How do we make sure that we are more geared for this? And like I said, fortunately, so many people have been trained and so many of the palliative care services had started, but still, you know, lots of work ahead, and we had to action things quite fast. So we came up with how our response plan would look like. Now, what we had and what we knew we had known palliative care patients who were COVID-19 negative, who would now require continued support in their homes through the community health workers and the primary health care and support team, right? But then we also had known palliative care COVID-19 positive patients that we had to cater for, and how we would ensure that the patient and the family chose, what would we do and how would we support them if they chose home care and death at home? How would we support them if they required admission into a facility? What facilities would be appropriate? And we had to look at the role of our intermediate care facilities for admission of known palliative care COVID-19 negative cases. And then in a primary health care setting also, we had to look at how the primary health care level supports the community health worker who supports the family in the home, caring for the known palliative care COVID-19 negative or positive patient. We had to also look at how we streamline medication collection and delivery and access to admission. And then also we had to look at from an, oops, I think I've jumped. We also had to look at from an inpatient level also, what would we offer for, how would we offer care for the identified patient who is COVID-19 positive but requires inpatient facilities. And of course also, and also equally important, was hospitals at all levels and field hospitals and their role in providing palliative care. This screen I won't spend a lot of time on, but just to show you how we actually took...
Sorry, Juanita, may I interrupt? Sorry, just take another minute if you can to get us...
Sure, thank you. Just to let you know that we had identified the need for 795 palliative care and end-of-life beds across the province. And essentially the model looked like this. We came up with what did we need to have in place for a known palliative care patient who is COVID-19 negative to ensure that they remain negative. And if they were exposed, how would we channel them through the system? We also had to come up with a plan of what we deal with how we deal with a COVID-19 positive client who deteriorates and requires palliation and needs to be rapidly channeled through into a palliation process for them and their family. So this is sort of what our model looks like in order to deal with that. And I suppose what we need to keep in mind during the pandemic, and this is the big thing, palliative care is not yet business as usual in the public sector services, because historically we've been focusing on prevention, promotion, curative and rehabilitation, and we were still at the starting blocks in many areas. The big thing we had to keep in mind and focus on was the spiritual care gap, which was significant and needed attention. And then of course, social workers and their crucial role for both patients and staff were not fully explored. And that's something we had to really drive home and push and still continue to push. And I think the big thing that I think most of you know is that we're still dealing with many myths around end-of-life euthanasia, morphine trust, etc. And this is basically how we tried to hold the space during the time of the pandemic. And I hope that this presentation has shared with you where we've come from and how we're progressing. And there's still a lot of work ahead, but this is where we are at in the Western Cape. Thank you for your time.
Thank you very much, Juanita. That was excellent. These slides are available and will be made available on the recording. I'll give you more detail toward the end of the session as to how you access all of the information. But once again, thank you, Juanita. That was a lot of information, and thank you for keeping it in the time slot and very, very appropriate. Much thanks. Our next speaker is Dr. Emmanuel Luirica, who is the Executive Director of the African Palliative Care Association since August 2012. He spent 9 years as Director at May International in Uganda, where holistic care, training, prevention, and research for HIV and related conditions were provided. He studied medicines at Makerere University in Uganda, family medicine at Medunsa, and Public Administration at the University of Stellenbosch, both in South Africa. He has been actively involved in palliative care development, both in Uganda and across Africa, and he serves on numerous boards, including the Worldwide Hospice and Palliative Care Alliance. Thank you very much, Emmanuel, for being with us. Over to you.
Thank you very much, sir, for that kind introduction. I'll go straight to the presentation. I'll focus on accelerating access to palliative care, COVID-19 and beyond, and focusing mainly on the global and regional context within Africa. I'll do it through reviewing the global frameworks, the regional and global data, as well as models and packages that have been developed, and then a way forward with COVID-19 that we have. As I've been introduced, I work with the African Palliative Care Association, and we work towards 4 main objectives, as you see them over there: creating awareness about palliative care, supporting integration of palliative care into health systems, evidence generation through research, and sustainability for palliative care at the organization and for our membership. One of the things that WHO gave us was the definition of palliative care in 2002, and that has given us a starting point so people know what palliative care is and, in a summary, how it is supposed to be done. But we have key facts. We know that palliative care improves the quality of life of people facing challenges associated with life-threatening illnesses, whether physical, psychological, social, or spiritual. But what faces us most are the gaps and the needs. We know that globally over 40 million people are in need of palliative care every year, and 78% of these are in low and middle income countries where Africa falls. We also know that only about 14% of those who should be getting palliative care actually get it. We face challenges of inadequate programming in countries, limited resources, limited training, and therefore this creates a situation where we need to take action. And in 2014, at the World Health Assembly, a palliative care resolution was passed where all members of the World Health Assembly unanimously passed it. And that resolution has 9 focus points. 1 focused on policies, where governments were supposed to strengthen their policies and also ensure adequate domestic funding and allocation of human resources. And then the 3rd was to provide basic support for patients and all others who are involved, as well as making sure that palliative care education is part of the package that is being provided, supply of essential medicines, revising legislation, and updating their medicines lists, essential medicines lists, as well as fostering partnerships between government and civil society. In 2017, we had the cancer resolution, which also referred to the palliative care resolution, and both resolutions address the issues around policy, education, essential medicines, and service delivery. We also have the political declaration on universal health coverage, and as you know, promotive, preventive, curative, rehabilitative, and palliative are all part of the services that are supposed to be provided. And without palliative care, it cannot be universal health coverage. In 2017, we had the Lancet Commission report. If you look at that as the map of the world with the distributed opioid morphine equivalent in milligrams per patient, then it shows you how Africa almost disappears from the global map, therefore the challenges we face. In that report, a package was recommended, and that has medicines, medical equipment, and human resources that countries should adopt. It has key messages that focus on alleviating the serious health-related suffering, universal access to affordable, essential, and of the poor people to access the package, and then collective action globally and generating better evidence and setting tools that to measure what we need to push this forward. The African Palliative Care Association also published an atlas, the reference is attached there, which showed the progress in Africa. Unfortunately, the progress was poor in most of the African countries. Then we have the Global Atlas, which has just been published, and it also shows that the majority of adults, 61%, that over 56 million people need palliative care every day. That's the recent data, and 67% of those are adults over the age of 50, and at least 7% are children. So the challenge that we face is huge. We know that in Africa, HIV has made that need worse, and therefore they need to take action as a region to improve on the lot of our people. And then we have 4 groups of countries in there, those with no known palliative care programs at all in group 1, and then in group 4, where you have countries at preliminary stages of integration, like South Africa is in group A. And then the top performing group is group 4B, where we have Malawi and Swaziland. The African Palliative Care Association, working with partners, has developed a package that countries can use to integrate into their national UHC plans, and that has essential palliative care medicines as recommended by WHO, essential medical equipment, patient support devices and technologies, as well as supplies, human resources, and psychosocial interventions, and that can also be accessed. In terms of palliative care and COVID, in order for us to provide palliative care for COVID and other emerging diseases, Africa does not need to reinvent the wheel, but utilize existing regional and global frameworks already in place to prevent unnecessary suffering, so that we can respond whenever there's a new action that requires to be added, but when the background has been set. Without this prior consideration and investments, subsequent needs generated by COVID and other emerging diseases, as well as the traditional ones, in addition to NCDs, will be impossible to meet. Thank you very much.
Thank you very much, Emmanuel. That was the most comprehensive input. And it's clear from both the previous speakers that a lot of thought has already gone into formalizing palliative care in terms of its remit and its scope. Of course, state action is often lacking, but it's really gratifying to know that this much of thought has gone into it, this much of work has gone into it, and that your point, Emmanuel, at the end, that we shouldn't have to reinvent the wheel. That's quite encouraging that we actually do have the wheel. Thank you very much for that. Our next speaker is a very special person. Nancy Minnie is a professional nurse with 35 years experience in diverse fields, including midwifery and public health. She's passionate about HIV, AIDS, and oncology services, and was involved in clinical trials in both these areas. After the tragic passing of her oldest son, Vuisile, in 2018, she enrolled in and has recently completed the University of Cape Town's postgraduate diploma in palliative medicine. Nancy has also recently suffered a further tragedy, losing her husband, Clarence, who's well known to many of us, to COVID-19. And her experience during that time could not be more germane to this topic. Nancy, the floor is yours.
Thank you. Good afternoon. My husband, Dr. Clarence Minnie, passed on in May 2020 due to complications related to COVID-19. And my family and I have been deeply scarred by the gaps in care that we experienced. At the time of his passing, Clarence was the board chair of the Council for Medical Schemes. We both had medical training, access to private healthcare, and political leadership, and none of this protected us when COVID came knocking. I asked myself, what is it like for other families then? So I took it upon myself to write to Minister Mkhize to highlight some of my family's concerns. I am grateful that he did respond. He shared my letter with the hospital group's CEOs, and I was able to have face-to-face meetings with them to discuss our experiences and unhappiness of some of the events which transpired. I am most grateful to the minister, the specialists, other medical colleagues, friends, and family who supported us throughout Clarence's illness, during the funeral and up to now. However, I feel there's a lot we can still do together to help other families. And for this reason, I share my letter with you today. And it goes, and I wrote this in August of 2020. Dear Minister Mkhize, I trust my email finds you well. Thank you for your leadership in fighting this pandemic. It is 3 months since Dr. Mini passed away, and I have been asking myself what I can do as a healthcare worker and a citizen of South Africa. I had hoped we would have had time to chat about my family's experience in person, but I recognize that you have been inundated with leading the country in trying to contain the pandemic countrywide. The challenges are many. As a family, we were subjected to unpleasantries which have left us quite scarred emotionally. And as a nurse, I ask myself, what would I have done differently? And what can I do to make sure that my fellow South African families do not experience some of the things we did? The level of care was not always what we were made to believe it was. And I think during this COVID-19 pandemic, there is more we can do as healthcare professionals. We need to collaborate more and work collectively, especially with allied health professionals like your social workers, psychologists, and more so, palliative care specialists, as well as the religious and spiritual leaders. I personally am advocating for more recognition of palliative medicine and care, as I think we as a family could have benefited when Dr. Mini was ill. He was severely affected by the COVID-19 disease, and I'm sure the specialists looking after him could have benefited by including these professionals. He was intubated early hours of the second day of his admission, and we were only informed when I went to the hospital at about 10:30 a.m. Sunday, 29th of March. The physician claimed he was very busy to give regular updates, so would only call us in the afternoon. We had to raise some noise by calling the hospital manager and senior executives. You yourself may remember being informed that Clarence was unwell, and that is when a few specialists were called in to assist with his medical care. Segi Pillay and you assisted us by calling on top specialists like Professor Guy Richards, and for that we are eternally grateful. The transfer to the second hospital, which we thought was a good idea, did not go without concerns. The admitting specialist did not always give updates, and in fact, on one occasion when questioned, she said, "I forgot." Often the lack of empathy was noted in the way she would call after 7 p.m. to give bad news, and then just say sorry, tell us we must pray, and then hang up, leaving me to deal with my children and convey the messages to them. On the 2 occasions when she said his condition had deteriorated, we asked to visit him, and even then, she did not make time to meet with us to have the hard and difficult discussion. Another major concern is, are the specialists and doctors allowed to perform procedures on our loved ones without any consent? I have many questions. As a professional nurse, I could see that my husband's condition was not good. I had to explain to my children my thoughts and try to prepare them for the worst outcome. I highlight these few incidences as I found them very disturbing. One understands that it's difficult during this lockdown period to meet with families. However, it leaves me wondering what else my loved one was subjected to because he could not communicate, and we were not informed of everything that was going on. Communicating with families is key during this pandemic, and I think there is a huge gap. Specialists cannot do everything themselves. The day he passed away was probably the most traumatic, Monday, the 11th of May, 2020. The Sunday, 10th of May, the admitting specialist did not call all day, only to call at 4 p.m. on Monday to tell me that she'd moved Dr. Mini out of isolation ICU into a normal ICU and that we could go and see him anytime. My son pushed me to go with my daughter to see how their dad was doing. Well, to my horror and disappointment, when we arrived at the hospital, Dr. Mini was definitely not in a good way. The second specialist was by far more professional and empathetic than the admitting specialist looking after Clarence was there, and he explained that things were not all right. I should call my son and any family member who wanted to see Dr. Mini, as he was not going to make it to the next morning. We were then subjected to further ill treatment when we received a call at 1 a.m. and 5 a.m. on the Tuesday morning asking when we would collect Dr. Mini's body. It was an ICU sister and the matron calling. Again, another unpleasant experience for a family who had just lost a loved one. I do not want to bore you with the details, Minister, but I am aggrieved by what my children and I went through. And I highlight these few points to you because I know that after COVID-19, your ministry may be inundated with complaints and maybe a few families may resort to litigation. What is needed during this time is that families are kept updated about their loved ones' conditions. They should be informed in a professional manner about the inevitable death, especially if clinically the condition shows there will not be an improvement. Dr. Mini himself was very passionate about palliative care. He did the diploma in 2002, and I am currently doing the diploma with UCT. I shared my experience with my lecturers and fellow students who are part of the course this year, and many share my sentiments that there needs to be more recognition for the skills palliative care practitioners can contribute during this pandemic. We're all afraid of death, but why should a loved one die alone and not in dignity? Dr. Mini should not have died the way he did, in my opinion, and he could have been spared half of what he went through. The enormous medical bill that was incurred is a discussion for another day. My request, Minister, is that we continue to manage the psychological effects this pandemic is going to have on the affected and infected individuals and families. It is not only about the illness we need to take care of, but we also need to look at treating the patient holistically. Burials and funerals during this time are also abnormal for many of us and are actually going to leave us with major emotional scars. We are going to experience a huge increase in mental health issues. We are experiencing too many deaths at this time. And also the pressures on the current health system and the professionals. So I feel that there are many areas that we may be overlooking. I personally am pledging giving more of my time, despite my personal loss and pain, to make sure that as palliative care practitioners, we make a difference during this pandemic. Yours sincerely, Nancy Mini.
Nancy, I think I speak for everyone when I say that was very moving, and we owe you a debt of gratitude for raising the issues you did with the minister in your letter. They couldn't be more clear and couldn't underscore more the need for an appropriate approach to both palliative care during this pandemic for patients with COVID-19 and for others facing that fate. So big, big gratitude to you. Thank you very much for sharing that.
Thank you, Dr. Dasu.
Our next speaker is Tertia Berger, who, pardon me, I just need to get Tertia's details. Good. So Tertia Berger brings us the hospice sector's approach to palliative care and the challenges they're facing at the moment. She is the CEO of the Stepping Stones Hospice in Alberton and a board member of the Hospice Palliative Care Association of South Africa. Prior to founding the hospice in 2013, Tertia lived a very different life, working in the defense industry, and for a time lived in Saudi Arabia, Yemen, and Afghanistan. Today, she shares her fascinating journey with us. Thank you, Tertia. Over to you.
Thank you very much. I just need to do that. I'm so grateful for the opportunity to present a case for home-based care. Sorry, there we go. As an alternate to hospital care. Today, I'm going to be wearing 3 hats. I'll be speaking to you as a family member, as a patient, and as a hospice representative. Both my father and my daughter received home-based care from hospice. My dad had dementia and lived with me the last 2.5 years of his life. And although he never forgot his manners, he forgot how to shower, he forgot my name and couldn't find his ensuite bathroom. Our choices were a nursing home or home-based care. We appointed a live-in caregiver, and Dad proposed to every day, as he couldn't live in sin under the same roof. Having Christine care for Dad allowed me to continue my work, which entailed spending long periods of time overseas. He never missed me, but his dignified life continued gently. Then Dad started falling. He was admitted to hospital after a particularly bad fall, and due to his disruptive behavior was moved into ICU and sedated, where he developed pneumonia. The drips and constant movement drove him to the edge of madness. I stopped all treatment and brought him home, and under the supervision and support of hospice, he spent the last week of his life surrounded by his family, and he died a peaceful, dignified death when he simply forgot how to breathe. My second encounter with hospice, and really the reason why I started Stepping Stone Hospice, is my daughter Vicky, who was born with osteogenesis imperfecta. Blotched back surgery in 2002 resulted in 81 abdominal surgeries in the last 10 years of her life. Vicky battled uncontrolled and debilitating pain, nausea, septicemia, open wounds, and high output fistula. Vicky spent years of her life in hospital and ICU. In 2012, she made the decision to have no further surgeries or hospital stays, and she made us promise that we would love her enough to let her go. Once under the care of hospice, Vic's life changed. For the first time in 10 years, her pain was under control, and she was able to spend precious time with her children. Vic died a dignified, pain-free death 5.5 months after starting on the hospice program. Personally, I could never understand people's resistance to hospitals, not Vicky's or anybody's, because being a very healthy person, I really imagined that it was a holiday where my meals are served, there's no chores or work, lots of smiley visits, flowers and chocolates. Then I got COVID. My SATs fell to the mid-70s and I was in serious trouble. Our hospice doctor arranged for an ICU bed and a physician to care for me. And I cannot remember much of the conversation we had other than my overwhelming fear of being separated from our family. And I chose to remain at home. Between Dr. Rodriguez, Stepping Stone, Sister Margie, and my grandson, John Daniel, I survived. And I will be forever grateful to them for caring for me in the safety of my home. Listening to Nancy's horrific story just reinforces that again. Palliative care should and must start at the time of diagnosis, and not only at the end of life, like the case with my child. When patients' medical aid funds run out, or when they're imminently dying, and the clinicians wish to dispense of the undesirable work of issuing death certificates. Palliative care is provided in care centers and hospitals, inpatient units, and in home. Sadly, as we've heard, there's currently hardly any palliative care in South Africa, in the hospitals, with the exception of Grooteskieu, Victoria and Chris Hani Baragwanath, where passionate individuals have driven this. There's very little or no palliative care in hospitals, both state and private. Home-based care is the most cost-effective healthcare delivery, and Shivani, I'm sure, is going to speak to that. Worldwide studies have shown that home-based care promotes healing in the comfort of the patient's home and reinforces with reinforcement and supplemental care from the patient's family and friends. There's a huge increase in the demand for institutional care for non-communicable diseases. And there's a lot of money to be saved in avoiding unnecessary trips to hospitals. It's important that we understand that home-based care is not second class care or cheap care for those who can't afford hospital care. The Hospice Palliative Care Association have developed the first quality council for trades and occupations, NQF level 2 and 3, accredited courses for caregivers, which are grounded on evidence-based practices and standards of care. The NQF level 2 course comprises of 80 hours of lectures, 300 hours of practical simulation, and 300 hours of workplace training. That beats many of the caregivers out in the industry who have only got a basic first aid course training. Home-based care takes place under an interdisciplinary team, which comprises of a palliatively trained doctor, nurses, caregivers, social workers, allies, pastors, and it all happens in the comfort and familiarity of a patient's home environment. The home care sisters assist in managing symptoms such as pain, nausea, constipation, incontinence, bed sores, sleeping patterns, as well as offering advice on dietary problems. The most important aspect of home-based care is that it allowed me to be a mother and a daughter. I got to spend sacred time with my child and my father when they were at their most vulnerable. In an ICU, I could see them for an hour a day. And often the nurses would work on them during that period, and I wasn't able to see them in the hour allocated to me. So I want to thank you all for listening to me and allowing me to present a case for something that I really believe in with every fiber of my soul. And I hope that combined, we will make a difference to this world that we work in. Thank you very much.
Thank you, Tersh. Thank you very much for another very moving presentation. Both you and Nancy, I think, bring home the personal in a very political way. And it's important that it gets told in that way, because the idea is not just to make people think about it, but to get governments and organizations to move on it. So once again, thank you very much. That was an excellent presentation. We move on to our next speaker, and that is Ms. Shivani Rancho, who is a healthcare actuary and academic with close to 20 years experience in the health sector. She's the co-founder and CEO of Percept, I beg your pardon, a transdisciplinary consulting firm, and is also the co-founder of Aligned, a company that offers end-to-end value-based financing solution for the optimal management of complex patients. Shivani works part-time as a senior lecturer at the University of Cape Town, where she was previously the head of actuarial science. She's also a long-term advisor to the Government Technical Advisory Center, a component of National Treasury. Shivani, over to you.
Thank you, Aslam. Good afternoon, everyone. So my journey with palliative care began about a decade ago. I was involved in a very actuarial piece of research at UCT, looking at healthcare costs at the end of life in medical schemes. The study results were startling. Medical schemes spend 12 times as much on those in their last year of life than on those who survived the year. This equates to 10% of their total spend on fewer than 0.5% of their beneficiaries. The sheer scale of the spend on end-of-life care, so to put it in context, we're talking about more than 20 billion Rand in 2021 terms, didn't accord with my personal experience of the system. The depth of the suffering of patients and their families at the end of life. Aggressive, invasive, and non-beneficial interventions right up until the last moment. No real emotional preparation for the end, and profoundly uncoordinated care. I think echoing a lot of what Nancy described in her experience. I co-founded a company called Aligned to work on solving this problem, and I've spent the last 2 years convincing medical schemes and insurers of both the moral and economic benefits of investing in palliative care. The economic case in the private sector is clear. When you pay attention to patient preferences and you provide support to them and their families, the trajectory of care inevitably switches away from expensive interventions in acute settings towards home and hospice-based care. This simultaneously costs less and results in a better experience for the patient and their family. In considering a unified health system, we need to think about the case for palliative care in the public sector too. The economic case for palliative care isn't just about end-of-life care. There is scope for palliative care along the life course, supporting patients with serious illness and for patients living with chronic illness. In a country like New Zealand, palliative care is woven into every aspect of their healthcare system. And this is what we should strive for. In thinking through building an economic case, there are 2 sets of questions to answer. The first is, if we spend this money, is there a return on investment? In other words, do we get something for the additional money that we spend? The second is, which is relevant when we work within a constrained fiscus, is do we have more to spend? Will we have to spend more? Or is there an offsetting cost to the system? What this means is that even if something yields obvious benefits, the resources may not be available to make the investment. This is particularly true when we think about investments in healthcare or investments in doing something new as additional incremental spend, and we don't think about reprioritizing across the system more broadly. The very first client that we helped at Aligned was the husband of a patient with cancer being treated in the public sector. The wife had been in hospital but had been discharged, and the family thought that this meant that she had been cured. But in reality, she had been sent home to die. We worked with the family to support them through this realization, providing them with an opportunity to make peace. Unlike the private sector, the response to the dying patient is frequently not one of excessive but non-beneficial care, but rather a choice to not expend further resources. The moral case illustrated by the story, I think, is very clear. Every person deserves a compassionate healthcare system characterized by humanity and by dignity. What this patient deserved, which actually would not have cost more money, is to be helped to understand why she was being discharged and what her clinical outcome was likely to be prepared for her death. But what about the economic case? So providing the aligned patient with palliative care would have cost the system more than simply abandoning her and her family, albeit not much more. But the basis for our comparison cannot be the failure of the status quo. If we look beyond just the healthcare system, the economic costs of the way in which we do things are very, very clear. There are losses to our economy associated with caregiver responsibilities. And these caregiver responsibilities fall disproportionately on women. There is also a very serious impact on productivity associated with complicated grief, the sort of grief that Nancy talks about. And this is powerfully illustrated by COVID, and the evidence to support this is emerging globally. For every person that we have lost to COVID, there are on average 3 people grieving the loss. And much of that loss, much of that grief and that loss has been complicated by the way in which treatment has unfolded and by people being separated from their loved ones at the end. Thinking beyond the short-term and direct costs to the health system requires budget processes that extend beyond rigid line items. It requires a radically different mindset, and it requires political will. Any reorganization and reprioritization of a complex system requires leadership. This is so powerfully illustrated by Juanita's presentation about the Western Cape Task Team and her own passion for furthering the cause of palliative care in the Western Cape. We need to think about the investment in palliative care not as a single homogeneous decision. It isn't a matter of whether we have palliative care in our system or we do not. We need a series of changes in our healthcare system. Everything from how we train all cadres of healthcare workers, how we best use community health resources, how we address questions around pain and other symptom management, and how we resuscitate an ailing hospice sector. Each of these decisions needs supporting technical work. Some interventions, like building more empathy into the system, cost nothing. Others will require more thought. The overall economics of a health system are relatively straightforward. You have the allocation of resources on one side of the equation and health outcomes on the other side of the equation. In other words, the reason that we spend money on healthcare is to improve patient outcomes. The outcomes that matter for patients with serious illness relate to relief from the stress and symptoms, from their stress and symptoms, support for their family, and the dignity of having your preferences listened to. We don't currently have an economic basis for our health system as a whole because we only very crudely measure outcomes, nor do we have a sense of the outcomes that actually matter to people. A patient-centered healthcare system is the only economically sensible model, one in which you pay close attention to what matters to people and then organize care in order to deliver what matters. This ethos is central to palliative care, and it is not possible to have a patient-centered health system that does not have palliative care built into its bones. Thank you.
Shivani, that was superb. Thank you. That for me, for the first time, identified palliative care within the matrix of the kind of health systems we have from a financing point of view. So that was superb. Thank you very much for that input. Much appreciated. Good. We now invite one, if I've got to get this right, sorry. Right, our next speaker to be invited is one Mark Haywood. Very well known, I'm sure, to all of you, but let me just remind you who he is. He's a South African human rights and social justice activist. He is the co-founding editor of Maverick Citizen, the civil society social justice segment of the Daily Maverick, South Africa's most widely read online news source. Mark studied English language and literature at Oxford University and African literature at Wits. Between 1997 and 2010, he led the AIDS Law Project and thereafter served as the executive director of Section 27. He is also the co-founder of the Treatment Action Campaign, the AIDS and Rights Alliance of Southern Africa, Corruption Watch, and Save South Africa. There's much more than what I've said about Mark. But for all of us who have been in this country over the last 20 years, you will have understood the invaluable contribution he's made for the rights of people to be treated and cared for. Thank you, Mark. This floor is yours.
Thank you very much, Aslam, and good afternoon to everybody. And thank you also for including the question of human rights and access to palliative care as a human right within this very important, informative, and moving discussion. The key words that I have heard from the presenters before me this afternoon are that palliative care is integral, that it is essential, that it is linked to dignity, that it is part of the continuum of healthcare and not an optional add-on or a luxury for a health system. And then in the last few minutes, importantly from Shivani, that palliative care is cost-effective, that it is cost-saving, and that it is cost-beneficial to the healthcare system as well as to society as a whole. And I guess the big question that we have to ask is, if we have all of these benefits, why is it that palliative care, as was said by several people today, by Tertia and others, is almost non-existent in our public healthcare system? And whilst there may be lip service at times in our private healthcare system, as we heard movingly from Nancy, the practice is something very, very different altogether. And in the course of this afternoon, one of the throwaway lines I felt came in fact from Dr. Dasu, who at one point said, of course, state action is often lacking when it comes to palliative care. And I wondered why it is that we accept that it is, of course, often lacking. And that's why my argument this afternoon, because there's no question in my mind that palliative care is a human right, that it is a legal right, that it is a constitutional right, and that it is an enforceable, what lawyers call a justiciable right. There's no question on any of those scores. So my question is really, why is it that it is often lacking? Why is it that there is a gap between law and practice, between our law and our constitution, as I'll show you in a minute, and practice? Why is it that there is a gap between policy, because we have policy on palliative care, and I can show you it going back many years, and its implementation? In fact, as I was preparing for this afternoon and looking through the depths of my computer, I even came upon a submission from 2007 by the Palliative Care Association when we were drafting the National Strategic Plan on HIV. And I know for a fact that 2007 wasn't the beginning of the point of advocacy for palliative care. As I was preparing for this afternoon, I was assisted by colleagues who told me, and we've heard it reinforced, that palliative care is still mostly an NGO function that reaches less than 20%, and that's probably an overestimate of people who would need palliative care. I've been working with advocates for palliative care for children, of which we've heard insufficient this afternoon, and perhaps if I was to make a criticism of this afternoon's program, it is leaving off children's needs for palliative care. But there are up to 1 million children in South Africa in need of palliative care services, with an unmet need for palliative care. And the final thing I would say about the facts of what we're confronting is that even though we heard from Juanita about very important progress in the Western Cape, and there is some evidence of a little more than lip service to palliative care in other provinces, the gap between what is provided in public and a contracting palliative care service in the NGO sector points to a shocking failure to protect rights. Just one fact I was given. In 2010, there were 201 hospice services in South Africa. At the end of 2020, there were 104, most of them having collapsed due to lack of funding. Now you have to ask yourself, why is it that something that saves money, but more importantly, because this is ultimately not about money, which is central to dignity, is not receiving funding, which is why, for me, this is a question about how do we campaign to raise awareness of palliative care and organize an unapologetic demand that this should be part of our public system, both in the public sector and in the private sector. Let me now just very quickly, in case you need convincing, say a few words on the law when it comes to palliative care. You all know that our constitution promises that everyone has a right of access to healthcare services. And we heard from Dr. Luirica about how the World Health Organization considers palliative care as being an essential part of the right to healthcare services. But it goes even further than that, because when we come to children, and I've mentioned that 1 million children in need, children's rights to healthcare services are set at an even higher level. Children have a right to basic healthcare services in Section 28 of the Constitution that is not limited in any way by available resources, that is not qualified by progressive realization and so on. They simply have a right to basic healthcare services, and the state is under an obligation to meet that right as soon as is possible. Now, I would argue, as I'm sure you would argue, that palliative healthcare services are part of basic healthcare services when it comes to children. Again, not a luxury, not an added option, not an add-on, essential to children's healthcare. And then there are other rights. Take aside, leave aside for a moment the question of healthcare services. Foundational to this right is the right to dignity, and I would argue the right to life, because the right to life is not just a right not to die, it is a right to live with dignity. And I think one thing we should be careful, and I'm sure my colleagues would all agree with us about this, is that we've spent a lot of this afternoon talking about palliative care as if it is an essential part of dying without pain and dying in dignity. But palliative care is also essential for many people in order to live without pain and to live with long-term chronic illnesses and to remain a productive and functional member of society, member of family, and so on and so on. So our constitution is clear. And I believe that an argument for access to palliative healthcare would be supported by jurisprudence, by cases such as the Treatment Action Campaign case, the Grootboom case, which you remember was about housing, but which set out what are the responsibilities of government when it comes, pardon me, to realizing what we call socio-economic rights. But I would go further, because given that we have a policy that promotes access to palliative healthcare services, there is therefore a duty to have a budget and to have a system for implementing and monitoring those services. I'll finish, there isn't time, I know Dr. Dasu will interrupt me in a second, but I would also say that what I've just said about our law is supported by international law, and our constitution requires that we must take account of international law, and the fact that South Africa has ratified, which means that we must domesticate international laws such as the Convention on the Rights of the Child, the Convention on Economic, Social and Cultural Rights, and all of the general comments and so on that go with that, expanding upon and explaining what those means. We are a member of the World Health Organization, and I can't remember, it was Emmanuel possibly, who talked about the 2014 WHO resolution on palliative care will remember that South Africa was a co-sponsor of that resolution, which makes the gap between what we say and what we do all the more problematic. Let me finish by saying that I think the challenge we have to face, because I must say I'm becoming tired of talking about lack of access to palliative care year after year after year, is the question of what must be done. And the COVID-19 epidemic and its aftermath will make that question even sharper. I believe we were presented this afternoon by Juanita with a model for palliative care in a province that we should look to, that we should learn from, that we can treat as a standard, as a perhaps not yet best practice, but certainly a very good practice. We heard from Emmanuel about the World Health Organization's 9-point plan. And underneath each one of those 9 points that were listed, we should have a plan. We should have a plan on how, for example, we ensure appropriate regulation of the medicines that are required for palliative care and so on. So let me stop there. I believe I've probably gone a minute or two over my prescribed 7 minutes, but I hope that the point is clear, and thank you for looking at this issue as an issue of fundamental human rights. Thank you.
Thank you very much, Mark. I would have been happy to let you go on talking. You're talking about such important things. And your concern about the rights of children is pretty much what we also have in mind, which is why we've also asked Glenda to speak. But before I bring her on, just to say that I think that what I've heard right up until your input is a case for palliative care that is not ignorable at all. And thank you very much for delineating the legal and the human rights components of this. I think it bookends a lot of what has come before us. Thank you once again for your time. Much appreciated, Mark. Okay, so our next speaker is also someone who probably doesn't need much introduction. That's Professor Glenda Gray. Now, I'm going to read the little blurb here, and I'm going to add a thing or two to it. She is a physician, a pediatrician, I should say, a scientist and an activist who specializes in the care of children and in HIV medicine. In 2014, she became the first female president of the South African Medical Research Council, a post that she still holds proudly. She's been awarded South Africa's highest order, the Order of Mapungubwe in silver, and in 2017 was recognized by Time magazine as one of the world's 100 most influential people. Last year, Forbes Africa listed her as one of Africa's 50 most powerful women. The other things I want to say about her is that she's an NRA-rated scientist with numerous publications behind her name. And moreover, she's a fellow of the National Academy of Science in the United States, one of only 17 Africans to be granted that honor. And she's also a comrade of many years standing and a friend and a leader. Thank you, Glenda, for joining us. The floor is yours.
Thanks, Aslam, and thank you for the panelists. I think you've given us work to do. So my question I'm going to pose today is, how do we use science, or how do we use health research to change the way we do medicine? And clearly, from what we've heard today, we have lots of work to do. But the beautiful thing about science is that science drives policy, science drives change, and we can use science as science advocacy to make sure that we implement the findings that we find in research. So how do we bring science into the issues that we've spoken about? So the important thing about the South African Medical Research Council, it's our job and our mission to fund and conduct research that changes the lives of South Africans. And clearly, palliative medicine is an area that we have to invest in and we have to work in. So how would we do this? We have 4 objectives, and one is to advance science, and I'll talk a little bit about later how we could do this for palliative medicine, both for COVID and non-COVID related work. We also need to build capacity, and we've heard today about the lack of support, the lack of training, and the lack of development in palliative medicine. So clearly we have a role to play in building capacity. We also have a role to play in using innovation, and I'll list a couple of areas where I think we can innovate in the role of palliative medicine and care. And also a very important objective is knowledge translation. And so it's our job to make sure that knowledge that is generated is translated into policy and action. And this is a very important role that the MRC can play in making sure that findings in palliative care get translated into action. So there are many things that we need to address in terms of palliation, and also in the era of COVID. At this moment in time, and we've heard from Nancy that in South Africa in the last 307 days, we have a country that is experiencing national trauma and national grief, and we need to find ways of documenting that trauma and grief, and we also need to find ways of dealing with this, and that's where science is very important, because science can pave the way to try and understand the processes of grief and trauma, and ways of helping people to address this and addressing the mental health issues that we see at a national level. We know that there are more deaths in the COVID epidemic than the documented reported deaths, and the MRC will this week show that more than 100,000 people have died during the COVID epidemic, and some of them are COVID related and some of them are not COVID related. And this is where the issue of care comes in, and how to make sure that both people with COVID and people without COVID who are dying in this epidemic die with dignity and in a way that their families can interact with them. We've seen decreased access to all chronic medicine, which means that we will see more deaths from TB and HIV. And that's an important thing to make sure that we can support the health system to minimize the deaths related to people not getting their chronic medicines in the time of COVID. We've also heard today about the decreased interaction of families being able to support their loved ones in hospitals, either if they have COVID or if they don't have COVID. And we need to address these issues. Nancy spoke about the lack of access, the lack of ability to be with her loved ones, to be with her loved one, Clarence, when he was in hospital. And we need to find innovative ways. We need to find innovation, and that is science, to help loved ones interact with their loved ones who are in hospital. And I just want to mention just some of the innovations. A friend of mine's father died in France from COVID-19, and his wife had just had it a week before, and they allowed her to come into the ICU, and she told me her father died in the arms of the woman that he loved. And we need to find ways in South Africa to do that kind of thing. We also see that in today in COVID in South Africa, it's very hard for loved ones to interact with their loved ones who are in hospital for either COVID or non-COVID care. And we need to find ways of making sure that there's better communication between the health system, the patients and their loved ones. And that can be hard with good innovation in terms of FaceTime, and making sure that we can find ways of bringing the loved ones closer to their loved one who's in hospital, and that we must move on. That's a science question, and we have to achieve that. In terms of pain management, we have heard already how poor we are at pain management and pain access, and part of science is to make sure that we improve pain management in Africa, and we need to do that as a matter of urgency. We speak a little bit about the mental health of the patients, of families and healthcare workers, and it's an important time in South Africa to try and make sure that we develop innovation to address the mental health issues of people dying in the time of COVID, and also people experiencing death in the time of COVID. We need to improve our communication. We need communication innovation, and we also need to make sure that we address the funding mechanisms that were spoken about earlier. So what can the MRC do? So we can support the implementation of policy. We can do operational research, we can do monitoring and evaluation, we can address the issues of pediatric palliation and how to improve the outcome of children who do find themselves in the need of dying with dignity. And so there's lots of work to do. So science has to work closely with areas of interventions. And the first thing that we need to do is we need to draw up a research priority for palliation, and then we also need to make sure that this gets funded. And I guess this is the first step to doing that. And I will be reaching out to all of you to strategize around what are the important parts of research, how do we prioritize it, and obviously then to deliver an RFA to conduct this research and make sure that we keep moving forward in terms of research. So thank you very much for allowing us to be part of this webinar and allowing us to offer our services in science to make sure that we improve the outcome in this area. Thank you very much.
Thank you kindly, Glenda. That was superb. Thank you, because it puts our premier research and medical science institution at the service of this very important issue. There have been, I need to say, there have been lots of questions posed, and fortunately, most of them have been answered on the Q&A, and we're grateful for those. Several comments have been made, and your comments have been passed on to the people that they most directly affect, and we're grateful for those as well. They'll be put as part of the package that will be made available of this webinar on the website of the Medical Research Council and others. I'll talk a bit about that shortly. So we heard today what states do and do not do enough of when it comes to palliative care. And Juanita and Emmanuel gave us a very, very clear exposition of what needs to happen and what is happening, and with a very stark gap in between. So we're very grateful to have had that overview from both of you. Thank you very much. We then heard the very moving stories of profound anguish of people with personal experience of both the lack of and where palliative care was provided. And it gave us, I think, a universal understanding of the personal in the role that we must play when it comes to the end of life for our patients. So thank you both, Nancy and Tertia, for grounding us very firmly in that personal experience. It certainly emphasizes why we have to go the way we do. We then heard and understand better now, having heard Mark Haywood speak, the imperative of a rights-based approach to all healthcare, including palliative care. And he couldn't have been clearer, and I'm not going to even try to summarize what he says, because he says it best. And of these inputs, I think we brought to a full circle by bringing in the voice of the professional, which I think Glenda carried very well on behalf of all medical professionals. Because if you're a health worker, you're automatically an advocate of palliative care. And if you're not, you need to check yourself, because it's pointless to be a health worker and not have palliative care as part of your continuum of understanding what it means to care for people. So Glenda, thank you very much for that, and for the magnificent support that this webinar received from the Medical Research Council and your excellent colleague, Patrick Charles, who's put it all together for us. This webinar will be posted, like I said, on the MRC website for access for anyone, anywhere in the world, and also presumably on the PALPRAC and HPCA websites. And just lastly, to thank the fantastic group who did all the heavy lifting here, Liz, Margie, Lee, Thank you all very much. I'd like to share with you at the end right now a poem that gave me great solace at a very difficult time, and which I've shared with a few people who experienced similar comfort. And it's just for a minute. Please, I hope you can take, please listen to it. I hope you can take the same value from it as I did.
And just before we go, amid the sad news and the anxiety that COVID-19 crisis is causing us all, we leave you tonight with one of Ireland's most famous poets, Derek Mahon, reading his poem, Everything is Going to be All Right.
Everything is going to be all right. How should I not be glad to contemplate the clouds clearing beyond the dormer window and a high tide reflected on the ceiling? There will be dying, but there is no need to go into that. The poems flow from the hand unbidden, and the hidden source is the watchful heart. The sun rises in spite of everything, and the far cities are beautiful and bright. I lie here in a riot of sunlight, watching the day break and the clouds fly. Everything is going to be all right.
Thank you all once more for sharing this afternoon with us. We hope it was useful for you. We will have learned from your inputs, and we will take this struggle to get palliative care as mainstream as possible forward. Thank you and goodbye.